Welcome to Voices in Value-Based Care. I'm Matt Fusan. Thanks for tuning in. The movement of value-based care is revolutionizing how healthcare providers get reimbursed for delivery of care. In this program, we're going to explore stories from the field about how real organizations are dealing with this change. You can follow the show on Twitter at #VoicesInVBC. On the program today, I talked to Dr. Larry Kosinski, or as he's known, Dr. K, which is what we'll use through the rest of the interview here, a practicing gastroenterologist and founder of SonarMD. Dr. K, welcome to the show.
Thank you, Matt. Pleasure to be here.
So, tell us a little bit about yourself, how you got started. I know you've had a long and illustrious career, and I know where you started and how you ultimately ended up what you're doing today with Sonar.
Well, I've been in the private practice of gastroenterology for over 35 years in the northwest suburbs of Chicago. We started way back as a three-man group and grew this group to over 50 physicians, which became the largest gastroenterology group in Illinois, and I was one of its managing partners. I've had multiple other leadership positions locally on hospital boards and chairman of medicine, nationally on the governing board of the American Gastroenterological Association. I've lived through two transition periods in the corporatization of private practice, the first of which was in the 90s when companies like Med Partners and FICOR bought up many private practices and ultimately failed. But this led to me obtaining an MBA in my mid-career, which changed the rest of my career. We're in the second period now, which has resulted in my founding of SonarMD. The link in all of this is my passion to use data to transform the practice of medicine.
Excellent. Can't wait to hear more. And, value-based care is something that I've been focused on in the transition for the last 5 years, and excited to hear about how you got there and what brought you to that. So what was the genesis of the idea that ultimately led to SonarMD and got you started? When did it hit you that specialty practices, and in your case, particularly gastro practices, needed a new way to add value to patients and get paid for it?
I watched over the last 20 years just about every gastroenterology practice transform from a medical practice into a colonoscopy factory. That's what fee-for-service did. As a result, we lost the differentiation of our revenue stream. We became totally focused on colonoscopy, so that today, 85% of the revenue of a gastroenterology practice comes from the performance of one procedure, colonoscopy.
That's amazing. That's an amazing stat.
It's a frightening stat if you're trying to run a business, because if something happens to that single revenue stream, you're in trouble.
Right.
At the same time, though, the market is in need of controlling costs, and over 80% of the total cost of healthcare in our country is the management of chronic disease. So it's time for specialists like gastroenterologists to pivot away from a pigeonholed revenue stream based on one procedure to one that provides the industry what it needs.
And that's an interesting take, because to date, typically the push has been for the primary care practices to manage all chronic diseases. So this is a little bit of a spin on it, and makes sense, right, to have the specialist help manage the chronic diseases that align very closely to their specialty.
There's been an interesting transition occurring in primary care practices. They have converted into practices being managed by advanced nurse practitioners. And the number of physicians that are practicing in primary care environments has actually declined. They are not capable of managing all of these chronic diseases. It's time for the specialists to be brought into this value-based arena. And in order to do that, they have to be converted from fee-for-service to value-based care.
So as you started down this path and you had a hypothesis, you ultimately went to BCBS and talked to them. What did you ask for?
Gastroenterologists take care of chronic diseases, irritable bowel syndrome, inflammatory bowel disease, celiac disease. But the most significant one that's most important is inflammatory bowel disease, since it is the one associated with most of the morbidity, mortality, and high cost. So I went to Blue Cross Blue Shield, and all I was asking for was cost data on Crohn's disease, the main inflammatory bowel disease, along with ulcerative colitis. All I was requesting was cost on Crohn's. What does it cost to take care of Crohn's? Where are the costs? It took several meetings before they agreed, but they ultimately provided me with an enormous database, an enormous claims database that spanned a 2-year period and included just about every Crohn's disease patient they had. We analyzed this. It took a while, and we confirmed that Crohn's disease is very expensive. It's about $40,000 per capita per year. And associated with that is a very high hospitalization rate. The medical costs are driven by inpatient care. Over 50% of the medical costs, non-pharmacologic medical costs, emanated from inpatient care. And these are inpatient stays for significant surgeries, bowel obstructions, abscesses, fistulas, bad things happening to young people. I looked at these admissions, and there was a 17% overall hospitalization rate. And the doctor in me said, well, how could these have been avoided? So I looked at the claims data in the 30 days before the hospital admissions, and this generated my first aha moment for the development of Sonar. When I looked at these periods, in over 2/3 of the cases, there was nothing. There was not one CPT code in that period. And as a result, these patients were deteriorating without realizing it. That was my first aha moment. We needed to develop a way to communicate with these patients and detect their deterioration, because if we wait for them to realize it themselves, it was too late. And that was the initial focus for the development of Sonar.
And after you looked at the data and realized what you realized, what did you go back to BCBS with? What was kind of your pitch, and how did they react to that?
Once I had the data and I knew what the problem was, we created a Sonar system. I think I was watching The Hunt for Red October, and I heard the word Sonar system, and it gave me this idea that we had to ping these patients. And so I took a very crude approach at first in 2013 in my own practice, and I provided 50 patients with a platform using our patient portal where I sent them a set of questions once a month. And this brought back a score. It was very cumbersome. It wasn't made for scaling at the time. My poor nurses were calculating Sonar scores on all these patients. But over the course of that year, on those 50 patients, we only had one admission and no surgery.
Wow.
So I went back to Blue Cross early in 2014, 2 years into this, and I presented that to them. And at the same time, they had been having a less than positive experience with their primary care patient-centered medical home. And so they were willing to take a gamble on us and make our group their first intensive medical home that they had ever, attempted with a specialty group. They attributed patients to us, and they agreed to provide us quarterly claims data on those patients, and they also provided a small management fee for each patient every month. In return, we had to agree to touch every patient every month in some way. Well, that was possible using a portal-based system, but it was very cumbersome. So I engaged a local technology company in the area I worked, and to take what I had created on our portal and move it to the web. And we had a web-based patient communication platform, and we deployed it on the 300 patients that Blue Cross Blue Shield had attributed to us. And we were off and running. And that was the beginnings of Sonar. We did this for a year, and we were getting quarterly claims data, so we knew exactly what the costs were and what was happening on our patients. And we were able to demonstrate a drop in hospital costs of over 50% and a drop in emergency room costs of over 70%. We published this, we presented it at national meetings, and Blue Cross then said to us, well, can you put this in other practices? And I said, yeah, I think I could do that. It's a web-based platform. It should be able to be accessible by any practice anywhere. So Sonar needed to become we needed to become a company because we had to get it out of the medical practice. And so SonarMD LLC was formed.
Those are amazing numbers. Having been in the field and investigating so many different payment models that CMS has put out over the last 5+ years, this has a bit of a feel of their comprehensive primary care initiative, or CPC, and now they're in the CPC Plus, which they're having some success with, but definitely not this level of success. So it's interesting. It's a little tweak on their primary care model, but it's amazing the numbers that you're realizing back by what is ultimately a pretty light touch with the patients that are using it.
The critical thing here is we are identifying patient deterioration before the patients are realizing that they are deteriorating. Most chronically ill patients who have symptomatic illnesses live in a symptomatic state that they consider normal. But if they have a condition like Crohn's or ulcerative colitis, where their symptomatic state brings them too close to their deteriorated state, complications result. So we follow a philosophy of the 3 C's. We connect, we calculate, and we coordinate. We connect with the patients regularly by sending out these clinical questions. We calculate their scores. Actually, the platform does it for us, and we've built in, some benchmarking through our own proprietary calculations. And then we coordinate care. Our care coordinators reach out to patients whose scores, either their rote score or the slope of their score over time, exceeds our benchmarks. And so we identified their deterioration before they even do, and the patients have told us this. So everybody benefits. The patients stay healthier, they stay out of the hospital, they have better access to their doctors, they have less out-of-pocket expenses. The payers are happy because it's increasing their value-based arrangements, they're saving costs, and the specialists benefit as well because they're incentivized to provide this care, and they're actually receiving a supplemental value-based payment for participation.
Yeah, that's awesome, and I like the 3 C's. I actually haven't heard it exactly that way: connect, calculate, coordinate. So now you've moved it out of the medical practice, right? So now it's a business, which means you got to get out there into the field and bring more practices on, and ultimately more patients onto the platform. So how have the practices reacted that you're out engaging with?
It's been amazing to feel the hunger in the specialty practices. Most people don't realize that just about every ACO, most of the shared savings programs are incentivizing primary care doctors for value-based care, but their specialists are still paid on a discounted fee for service. So it's almost as though the specialists are on the outside looking in. And what this has allowed them to do is to actually be participating and being part of the solution rather than being considered part of the problem. So there's been a lot of excitement amongst the GI community. We've got practices from coast to coast using our platform, and we've now got payers across the country that are participating as well. It helps because we're funded by Blue Cross Blue Shield.
That does help. You want to get those payers on board for sure. And like you said earlier, it's one of the few models, right, that's a win-win-win. Everybody's benefiting from it. And when I learned about the model, I kept running through my head. I'm like, this this almost sounds too good to be true, right? And kept running through it. And it really is one of those everybody wins type of a model, which is great to see out there, because almost always the feeling is with value-based care types of contracts, the clinicians ultimately feel like they're going to be squeezed. And it really is payer driven. And this is a good one.
Yes.
Where do you think's ahead?
It is so good to be true. Sometimes people can get suspicious and not trust it at first. But I think when they hear the full presentation and they see it, they go, oh, yeah, I can understand that. That's a simple solution. I can do this. So it really has had significant traction.
And Sonar supports those practices, right? So it's not just here's the software, but you provide supporting infrastructure around it, especially along the lines of getting the patients to sign up. Is that correct?
We've really take everybody by the hand and walk them through the process. What Sonar does is it positions itself between the payer and the medical practice. We are not interested in disintermediating the physician from the care. That's not our goal. Our goal is to augment that physician's ability to provide care by bringing his or her own patients to him at an earlier state of the deterioration process. So instead of that doctor seeing a patient in the emergency room at 10 o'clock at night, it becomes an extra office visit or it becomes a phone call. So what we're doing is the patient for the doctor. And so in order to do that, we provide the platform, but we are not a software company. We are a care coordination and targeted care management company. So we have personnel that monitor the pings. If the patient's scores exceed benchmarks, our Sonar personnel reach out to the patient and then provide the results of that communication to the practice. So from a doctor's point of view, the doctors that use our platform don't even know how to log into the platform. They're working inside their usual system of care, and they're working in their own EMR, and they're just seeing their patient earlier in the deterioration of the illness.
And I think that's just such a great business model, the way that you have it set up, because there's so many times and so many pieces of software out there that say, here's this great software, but you just bought a software, we give you tech support, but you're on your own for everything else, right? And everybody knows that nobody has resources sitting around waiting to take on a full-time job or waiting to do all care coordination, right? Especially if it's not going to be funded up front. So the business model really, really makes sense. So where do you see Sonar headed from here? Other single specialty organizations, what type of advice do you have for those out there? What's your vision?
Well, our success was something that was very measurable using Crohn's disease and ulcerative colitis. And the ROI was very, very calculatable right off the bat. And one of the reasons for that was our platform, but one of the other reasons was the type of illness we chose. So we analyzed Crohn's and ulcerative colitis and compared these conditions to the rest of the diseases in the GI state. And we've developed a term called high beta illness. We feel that Crohn's and ulcerative colitis are high beta illnesses, meaning they're high cost per capita, high variability in cost per capita, and symptomatic. Mm-hmm. So our platform then should be applicable to other high beta illnesses no matter what field they're in. And we've been working with the Blues in other fields of care to identify the other high beta illnesses. We feel that conditions like in the pulmonary space, chronic obstructive pulmonary disease, maybe asthma, in the cardiology space, congestive heart failure, in the musculoskeletal space, the metabolic, the diseases, rheumatoid arthritis and psoriatic arthritis. We feel that any symptomatic high beta condition should also be just as likely to benefit from a targeted care coordination program like ours as Crohn's and ulcerative colitis were. So one of the reasons I think the Blues invested in Sonar was because they saw the potential that this could have a much broader applicability than just in the GI space.
That makes sense. As we've talked about it, that's kind of where my mind was going, as it feels like this is a model that definitely could be duplicated into other areas and see similar success. So that's excellent.
Yeah, absolutely.
Well, thank you, Dr. K, and thanks to our audience for tuning in. Dr. K, we will certainly offer an invite in the future to have you back on. Tell us how things are going and where Sono's heading in the future. So thanks for joining us.
It'll be my pleasure.
You can learn more about the show on the programs page on healthcarenowradio.com and lend your voice to the conversation on Twitter, again at #VoicesInVBC. I'm Matt Fusan, bringing you the voices in value-based care you should hear. Till next time, have a great week.